Ladies and gentlemen, good afternoon and welcome to the Asian ICAS Consensus. To introduce our speakers is our moderator, the Deputy Chair of the Asian Intracranial Atherosclerotic Stenosis Consensus. Let us all welcome our moderator, Dr. Bonifacio Chia Pedregosa II.
Esteemed colleagues, distinguished guests, and members of the Asian ICAS Consortium, good afternoon. On behalf of the Academy, I extend a warm welcome to everyone to the PAVIN First Biennial Conference and Grand Launch. So this plenary is devoted to the Asian Intracranial Atherosclerotic Stenosis Consensus, a multinational collaborative initiative aimed at standardizing the definitions, diagnosis, and imaging of ICAS. So this afternoon, we are honored by the presence of international experts in stroke joining us online as members of the consensus voting panel, alongside official representatives from the World Stroke Organization and the Asia Pacific Stroke Organization, whose endorsement underscores the significance of this effort. So we are privileged to be joined by the President and immediate past presidents, Professor Craig Anderson and Jayaraj Pandyan of the World Stroke Organization, and Professor Suanuela and Dramani of the Asia Pacific Stroke Organization, who are also members of this consensus process. I would also like to acknowledge the presence of Dr. Alan Belen and Dr. Robert Gan, members of the steering committee who have been instrumental to this endeavor. So to introduce our first speaker, he is a man who needs no introduction. He is a pillar of neurological sciences and stroke medicine in the Philippines, whose contributions have had enduring impact regionally and beyond. He is a former president of both the Philippine Neurological Association and the Stroke Society of the Philippines. He currently serves as chair of the Neurosonology Group of the PNA, member of the executive board of the Neurosonology Research Group of the World Federation of Neurology, head of stroke services at the University of Santo Tomas Hospital and Jose R. Reyes Memorial, and member of the editorial boards of multiple international stroke and neurology journals. It is my privilege to introduce our mentor, Professor Jose Navarro, Chair of the Asian ICAS Consensus.
Thank you very much, Bonnie. I would like to acknowledge who are online. Bonnie, do you know who are online? I saw Vijay Sharma. I think it's online. Okay. So I would like to acknowledge the following: Dr. Kaysin Tan from Malaysia, Chong Hai Lee from Taiwan, and Vijay Sharma from Singapore. And they're part of the committee that have formed this ICAS consensus. Now, what I intend to do now is to present to you how we were able to come up with this particular project. So basically, reason why I asked my fellows and my residents is that we really noticed that there's really no consensus with regards to the diagnosis on how do we diagnose ICAS. So a patient with stroke, we do a transcranial Doppler, there is high velocity, he's got an ICAS. So that's our main diagnostic criteria. And it seems to me that we are lacking with regards to other parts or other criteria that we can use to say that this patient has ICAS. Because of that, we came up with some kind of a project, and of course I have to consult these other senior neurologists just like Robert Gunn. Senior in terms of knowledge, okay. All right. So what I would like to present to you this afternoon is how we came up with this consensus, all right? So what made us decide, or what made us do this particular ICAS consensus? So we entitled this an intracranial stenosis, Asian Consensus Recommendations and Standardized Definition, Diagnosis, and Imaging. So we hope that we will be able to standardize what we define as ICAS. So how do we differentiate ICAS from ICAD? So this is one main feature why we are doing this. And secondly, when do we make a diagnosis of intracranial atherosclerosis? And lastly, what would be the best in terms of ancillary tests that we could utilize in order to make a diagnosis that you're confident, if that 90-95% confident that indeed you are seeing a patient with intracranial stenosis. And we are really happy to tell you that this project of ours, which originated in the Philippines, okay, is now being endorsed by the World Stroke Organization through Dr. Panjan, the president or former president of the World Stroke Organization, the Asia Pacific Stroke Organization through, of course, initially through Romani, and then it was Dr. Suangwela was elected right now as the president of the APSO, or Asia Pacific Stroke Conference. And of course, lastly, through Alan Belen, the Philippine Academy of Vascular and Interventional Neurology. When Alan showed me the program, the initial program of PAVIN, I told him, is there a possibility that we could present the project on ICAS during the PAVIN? I think that's going to be a very good way of trying to introduce to Filipino audience what we're doing as far as intracranial stenosis is concerned. Hence, the ICAS program or the ICAS project was put into the program of PAVIN. Now, how it all started? Again, we noticed that there is a high disease burden of ICAS. Okay? High disease burden in terms of recurrence. I think it's quite high as far as recurrence is concerned, with our data coming from JR and also from UP. We noticed that our recurrence rate for stroke is about 7 to 8%. And when you look at the data of ICAS, it seems that it's much higher. They go even up to 25% recurrence rate. So this burden alone will indeed tell you that we really need to look at this ICAS and see what is the burden of this particular neurological disorder, okay, in terms of its recurrence. And it seems that the epidemiology remains still uncertain. I have done 2 studies on ICAS, the prevalence of ICAS, which is hospital-based. It's a hospital-based, and we noticed that it's about 40%. And if you go and review the prevalence in other countries, even hospital, there is one, a community-based done in China. You will see that, I'll show you later on, the variability, the variability of reported prevalences. And again, the definition, it's still unclear. When do you say that this is ICAS? The diagnosis of one group is that this is ICAS, but if you read another paper, you will see that their diagnosis is entirely different from the one that you have read before regarding how they define ICAS. So with this, it really gave us now reasons on why we need to review ICAS. And since it is really more common in Asia, I told the group, let's look at Asian data first. And then later on, if there is really something that we will be able to pick up from our data, then we might go now international and then look at all the international papers. And that review came out in the British Journal of Medicine, BMJ, and it was accepted for publication. And the paper is here. If you're interested, you can look at this paper. And let me tell you now, go on what are the different results that we came up in this particular paper. And again, you will see that if you look at the prevalence of ICAS by countries, depending on the country, this is from China, so you can see the countries behind, and Japan, and then also from Hong Kong. Even the prevalence is quite different. No? Some would claim about 20%, others, these are individual reports. So there is really a very great variability with regards to the prevalence. So some people, if you ask them and talk to them, because we always have a yearly meeting on ICAS, this is an international ICAS study group, they will tell you that our prevalence is 30%. Another country will tell you, we have about 50%. You know. Other will tell you, it's not really very common. We only see about 10 or 15%. So in other words, there's really a variability. And that variability probably is brought about by different definitions, by different diagnostic tests, which we'll be able to show you later on. And if you look at the prevalence of ICAS by modality, depending on what use, of course, we know that the more sensitivity, the higher the sensitivity of the diagnostic test, the higher will be the probability that you will be able to pick up ICAS. But if you have a diagnostic test wherein its sensitivity is quite low, then you don't expect to get a higher result or a higher incidence of ICAS. So in other words, again, depending on the modality that was used. So again, we said we need to review what would be the most common as far as modalities are concerned that was used all over Asia in regards to making a diagnosis of intracranial stenosis. And then if you look at the prevalence of ICAS by stenosis here, you will see the different issues different stenosis percent that they abuse. Some abuse at 20%, others abuse 40%, and then majority, you would say that anybody with intracranial stenosis, 50% and above is more significant. So from that time on, majority of workers in ICAS have utilized 50% and above, be it by transcranial Doppler, by TCCD, by other forms of diagnostic neuroimaging. As long as they go more than 50%, then they make a diagnosis of ICAS. Okay, so is this true? Because other workers, and this will tell you, that the significant stenosis, as far as ICAS is concerned, should be 70% and above. But other workers would like to use 50% and above. If you try to review the Sampris trial, they have used 50%. Okay? So you would see from here that there's really a severe or great variability with regards to stenosis, the modalities, and then the prevalence. And then what we did is to look at all articles regarding ICAS. And then from here, we were able to gather, using the Scopus and then other search engine, we were able to come up with 1,272 articles. And then following our criteria, meaning what are the different papers that we're going to study and pick up from out of these 1,000 plus articles. So we were able to reduce it, and up until we are now looking only at about 142 papers that have satisfied the criteria that we have set that we are going to use in order to look at the nature and the status of intracranial stenosis in Asia. Okay, so next that we are trying to look at would be the frequency of ICAS amongst patients with intracranial stenosis. So remember that we try to make a diagnosis of ICAS somebody had a stroke, you do all diagnostic tests, hopefully you would be able to see the cause of a stroke due to intracranial stenosis. So we do in our center, we do transcranial Doppler, we do neuroimaging, but later on we'll show you as we go on with the different groups and how they would be able to make up or how the process on how we'll be able to follow in trying to come up with this diagnosis test. Okay. And then you can see here, this is the frequency of ICAS in ischemic stroke by country. Okay. This one. And then this is the incidence, or the frequency of ICAS in stroke by stenosis. So we expect that, again, if we follow if we follow the majority of those articles and put ICAS and say that we call it an ICAS if the stenosis is 70% and above, okay, I think you will miss a lot. No, you will miss a lot because you will see that or majority of these ICAS will just be around 50%. Okay, so if it's 50%, we would call them an ICAS. Okay, so this is part of the Delphi that we have done. So we ask the expert and see whether 50% will be okay or 70% will be okay. So that would be the Delphi question that we have put into our Delphi voting. And these are the different diagnostic tests or modalities. Kid, pwede bang palakihin ito? Paano palalakihin yan?
Ito na po siya.
Hindi, gusto ko dito makita.
Dito po. Okay.
Malabo na mata ng lolo mo eh. Kaya hindi ko gusto
Ito po.
makita.
I-end show natin. Kaya na. Wait lang po.
Show. Hindi, yung show. Ito nga dito. Yan.
Ay,
Ay,
nag-ano
bumalik.
siya. Ayun. In presenter view dapat eh.
I'm sorry, because I cannot read the slides. The slides there. And I cannot read the slides there. Okay, that's it. All right. Now, these slides will show you the different modalities that were utilized in the different countries. Okay? Maliwanag na? Okay na? Okay. So there's different colors that represents MR, CT, ultrasound, MR, CT, and the other combinations. So you can see, depending on the countries, let's say, for instance, we look at China. China has utilized a lot of diagnostic tests. No? They have all these available diagnostic tests that they could use from CT scan, CT angio, MRA, MRI. Okay? And probably my paper, is it here? Yeah, in our paper you use CT scan, CTA, and angio. Okay? So probably from here you would see the lower the bar means that they have utilized only a few diagnostic tests. Those with higher bars, they have utilized a different diagnostic test. So China, of course, they have used a lot of tests. And then Korea, and then Japan. Fortunately, those in the Southeast Asia have just utilized one or two. Okay, so that's what we are represented in this particular graph. Okay. So because of this, what we have concluded is that, number one, the current evidence that we have gathered are still unreliable. They're still unreliable because of the different reported data, for instance, different reported prevalences. In one country, the prevalence is this, in other countries, the prevalence is that. Second, this decision-making will be affected. Because let's say, for instance, if one will tell you that if less than 50%, we don't call it ICAS. So we wait up until it becomes 50% or more in terms of stenosis. Is that reliable? We still don't know. And then, thirdly, because of this, there's no uniformity as far as the prevalence, and there's no uniformity with the diagnostic test, even researches remains fragmented. So you cannot rely on this research because it has utilized a different diagnostic test. You cannot rely on this paper because it utilized a different diagnostic test. So our purpose now is most probably make a uniform way of trying to report ICAS and what will be the accepted diagnostic test to claim that indeed we are looking at a patient with intracranial stenosis. So we made a call to action, and then this call to action was published in the Journal of Stroke and Vascular Neurology. And we're really happy to report to you that every time we make an article like this, journals journals that we have submitted this are really very, very supportive of us, you know. They immediately, read our paper and then give their comments. So I think our record is about 2 weeks. In 2 weeks, we were able to publish a paper. So that means that even the referees, even the editor-in-chief are really interested on what we are doing here. Probably they were really surprised. Those people in the Philippines are really working, no? Because in one of the conferences that I have attended to, I don't know, most probably some people there did not agree with me. It's only the Asian people who should be working on this because this is our disease. This is not the disease of white people. This is the disease of Asian people. Therefore, it should be the Asians who would be working on this. And probably that's the one that challenged me. Because I have said that, so I have to work on that. Pangangatawanan ko na. So the objectives of our project, when we started, is that our objective number one is to standardize the definition and the diagnosis of ICAS. When do we call it and when do we say that you are dealing with intracranial atherosclerosis? Because there are other conditions that will turn out to be positive by all these diagnostic tests that I've shown you, but they're not due to ICAS. You have moya-moya disease, you have dissection of blood vessels, but if you look at the modalities, all the diagnostic modalities, they will appear the same. They're identified. Even your transcranial Doppler will show you high velocity. So the diagnostic test seems to me would be not really a good way of making a diagnosis, not until we have first standardized what we call intracranial stenosis. The second objective that we would like to put up is the consensus of diagnostic modalities, meaning the group would answer what is the best modalities that we are going to utilize to claim that there is an intracranial stenosis. And the third group, there's a uniform measurement. So now at this time, when do we call it ICAS? If the stenosis is 50% and above, a 10% stenosis, a 10% will be called already a stenosis and then equivalent to ICAS. So we look at that. And then fourthly, we need to align the researches in standards and priorities according to what we have defined regarding this different objective. So if we follow now the objectives, meaning the definition that we have created, we follow the consensus as far as the diagnosis is concerned, and then we have a uniform measurement, and it will be followed all over the world. Different centers, probably we will be able to come up and say that indeed this is a valid paper because they utilize the criteria that we have given to them. So beyond standardization, this effort lays the foundation for regional collaboration. So this is one thing that we really would like to have, a regional collaboration. We probably should not start rather looking at different countries. Let's start in our country. Let's look at the Visayan, the northern part of our Philippines, and then let's collaborate and let's look at our data. Second, we build capacities across diverse healthcare settings and promotes equitable access to advances in ICAS care. And ultimately, we seek the position in Asia as the forefront of global ICAS research and enable meaningful international collaboration. Again, ladies and gentlemen, this is our view or our hope that whatever we're doing this in terms of all this consensus that we will be able to come up and produce will be recognized internationally. That is really what we want. That recognition internationally of this ICAS, which originated from the Philippines. Okay? And the way we carried it out, and this is the process, they are all evidence-driven developments, which means that we look at all the papers, all the articles published, and then review them, and then there's a rigorous multi-stage consensus methodology. So all in all, it took us about how much? 8 months. Yeah, 8 months, so 6 or 8 months. Right? 6 to 8 months. Because every now and then we meet about through Zoom meetings, and then we try to see different groups would report, okay? And then multinational world-renowned experts were invited, okay? So after we have formed the questions that we're going to direct towards our international expert through Delphi voting, and see which amongst the different statements that we have formed will the different expert will agree. Okay, so let's say, for instance, if we say that at 50% stenosis by transcranial Doppler is good enough to make a diagnosis of ICAS, so we have the expert to vote on that. So that's how the process was carried out. Okay, so it's an evidence-based, it's driven by evidence. The objectives formed by published scoping reviews. So through our scoping review, the first article that I've shown you, and there were 16 research questions over the 6-month preparatory review. So it took us 6 months to be able to produce the research question. Because this, I think, if ever you want to do, again, this kind of a study, that's the first thing that you really need to do. Formulate the research question. Because the research question is the one that will really pull you out and will be able to help you out in your project. If you don't have any research question, everybody will be going around not knowing to do what to do. And then 549 studies included out of 23,000 records. Look, we reviewed 23,000 records. Hindi ko magagawa yun. Hindi magagawa ni Bonnie lang yun. So we form a group. So you have 4 groups to review all these 23,000 records. And it's a methodologically robust framework, which means that it was conducted according to Joan Briggs Institute. So it's a published way of looking at how to format a scoping review, things like that. It's published, no? And you can look at that, and then how you form the prisma, which we're going to show you later on. So this is the process that we have followed. Firstly, we formulate the research question, as I've said. And it seems, in our experience of the group, this is the most difficult process to do. Itong pinakamahirap. Everybody should start here. How do you form a research question? Sa research question pa lang, awayan na yan. No? Kanya-kanyang utak yan. Imagine mo, in one group, you have about 8 or 10 people thinking, kanya-kanyang isip yan. And up until you will arrive, let's use this as our research question. And then you have the preparatory review, so the people now would be divided into several groups. Actually, we have 4 groups consisting of about 6 to 8 neurologists or stroke neurologists. And then the formulation of Delphi. So this group will now form the questions that will be subjected to all our experts. Okay, the experts will now vote whether to say yes or no on that particular census. And then we have the internal piloting, we start this and then look at it. We piloted it to amongst ourselves and see how it will come out. And then once we have done with the question, then we start with the Delphi iterative rounds. So we have done already the first round of the Delphi, and this is what we're going to present to you. So the way we're doing it, we come up with the research question, and then the questions that were forwarded to the different experts, and then what were their evaluation. Okay. So the consensus process is just a modified Delphi process, and you can see it here, that the expert independently and anonymously rate each statement. Now, we did this online, okay? Because we would like to avoid some issues. Let's say sa isang group, may matapang, may sikat. Kung ano sabihin nun, tatahimik na iba, right? Hindi na magsasalita yun, hindi na kukontra yun. It's not a Delphi. So what we did is, they're all anonymous. Hindi mo alam kung sino bumoboto. Okay? So they just vote. Kahit ikaw mahinang tao, mahinang klase, binoto mo yan, counted yung boto mo. Kahit yung isang pinakamagaling, alam na pinakamagaling yan sa ICAS and everything, it's not because you said that this is correct, you're always correct. Dadaan ka sa Delphi. Okay? All right. We have an agreement defined as 4 to 5 disagreement, and then disagreement as 1 to 2, and then neutral if they voted as 3. So it's a Likert scale, 1 to 5. It's a Likert scale. And then the consensus threshold, we place it at 80%. If 80% of the expert voted in a positive aspect, then the consensus will be carried out. Okay, so you will see later on, we have 24 statements, and you will see how many amongst there will pass the consensus. And then there's a free text comment, so we allow them to make their comments also online. And then the statements reaching consensus are retained and then removed subsequently if we will not be able to come up with our own consensus. And non-consensus statements are revised based on the feedback and reevaluated. And then if the steering committee agreed, they put it up again for Delphi, and then we put it up again for voting after the revision of that statement, particular statement. So now at this point, let me just present to you who are the people behind this project on intracranial stenosis. So you have Bonnie, our deputy chair, and then of course Dr. Robert Gans there, and Alan Belen. So this is the steering committee. So majority of those things that cannot be decided, the steering committee would decide. Parang sabi ni Obed yan, kung ano sinabi ng hari, hindi mababali. Yan ang masusunod. Okay. All right, so our international expert panel. So we have Ramani from Singapore, as I've said, Dr. Anderson, Professor Anderson, Suwangwela from Thailand, and then Panjan, the president of the WSO, World Stroke Organization. We have Aranillas from Spain, and then Dr. David Lavinskine from Los Angeles, Dr. Boss he represents both Harvard University and also the Leuven University in Leuven, in Belgium. And then Thomas Leung from Hong Kong, and then David Bonovich, Vijay Sharma, Chong Hai Lee. These are the expert panel. And then from the Philippines, we have Epiculiantes, Kaysen Tan from Singapore, from Malaysia, Adnan Qureshi from the US na lang. Okay. And then Song Kwon from Korea is the author of the TOS trial. No? And then, of course, our own Romy Sagundi. And then these are the people, yung mga younger age group, nagiging na-assign sa preparatory group. Okay? Younger age group. Si Sok, okay? Kasama yung mga mas bata, ayan, andyan si Teresa, si Gab, and then isa pang matanda, si Gabi, si Dr. Baro. Okay, the preparatory group 2 consists of course, Dr. Cañete, Angie De Leon, and then Faith Sabiliano. You have Ana Nade Solido, Diane, Mark Conrad, and then Danny Lagamayo. And then the preparatory group 3, I'm not going to tell you the topic, they're going to introduce to you the topic. So we have John Hiyadan, and then Cyrus, and then Dr. Basalo, Dan Wangko, and Timothy Cinco. And then for group 4, we have Dr. Joyce Tenorio, Christian Lim, and then Joe Roque, and Jane Lara. The study coordinators, we need the coordinators for this. No? So many things to do. So I need coordinators to be able to smooth out all the work that we are doing. So we have Gab, and then Mel, Monique, and of course our librarian. We need a librarian paghanap ng mga data. So she needs to go to different libraries to be able to get that particular article that we've been looking for. There's an article that it took us about 3 or 4 weeks to be able to get that article. And they have to go to the different libraries all over Manila. Okay, I think I have to end there, Bonnie. Okay, so that's it. That's how we plan the ICAS project. And hopefully, as I've said, once we have this project, my hope here is that it will be recognized worldwide, and it will recognize that it originated from the Philippines. Thank you.
Thank you, Professor Navarro. So we will now proceed to the next segment of the program, the presentation of the results of the first Delphi round, led by our distinguished colleagues who head the preparatory groups of this consensus. So first, I will introduce the heads of the preparatory groups, the next speakers. So our first speaker is a distinguished vascular neurologist whose contributions have significantly advanced stroke care in the Philippines. She completed her training in adult neurology at the University of the Philippines, Philippine General Hospital, served as immediate past president of the Stroke Society of the Philippines, and led the establishment of the stroke unit at Baguio General. She is also a past president of the Philippine Neurological Association and remains an active leader in national and regional stroke initiatives. She will address the first objective of the consensus, definitions and diagnostic criteria for ICAS. So this segment will be led by Dr. Maria Socorro Sarfati, head of Preparatory Group 1.
Good afternoon. So there are 3 speakers. Each speaker will give the objective of the research, and under each objective, the speaker will give an overview of the research questions. Okay. Sorry.
Wala pong keynotes doon.
This one, I'm still here.
Dito na po.
Yes. So going back, this is a non-voting session, but your inputs will be very important for the refinement of the statements for the second Delphi round. Okay, so I'm going to present the objective, the first objective of the research. It is to establish the standardized definitions of intracranial atherosclerotic disease, or ICAD, and intracranial atherosclerotic stenosis, or ICAS. And this will include thresholds for clinically significant stenosis across imaging modalities, and to differentiate symptomatic from asymptomatic ICAS. Under this objective were these research questions. First question is, what is the definition of intracranial atherosclerotic disease and intracranial atherosclerotic stenosis? 1.1a, how have ICAD and ICAS been defined and distinguished in existing literature, including current clinical practice guidelines, consensus statements, and reviews? 1.1b, what are the key diagnostic or pathological features distinguishing atherosclerotic from non-atherosclerotic intracranial arteriopathies? So this is the prisma flow diagram. Using the search word, we were able to see 1,686 references and 8 citations. For question 1.1a, there were 16 studies relevant to answer the question, and for question 1.1b, there were 21 studies included. The next question to address the first objective is, what constitutes clinically significant intracranial stenosis? Question 1.2a, how has clinically significant intracranial stenosis been defined across diagnostic modalities as reported in current clinical practice guidelines, consensus statements, and reviews? Question 1.2b, how do these thresholds correlate with clinically relevant outcomes? So this is the prisma flow. For question 1.2a, there were 26 studies relevant for the question, and for 1.2b, there were 24 studies. Please note the regional distribution of the studies to Asian and non-Asian. And the third research question for the first objective is, what is the definition of symptomatic versus asymptomatic ICAS? How have symptomatic and asymptomatic ICAS been operationally defined and distinguished in current clinical practice guidelines, consensus statements, and reviews? So this is the prisma flow, and there were 24 studies reviewed to answer the question. So the first Delphi round was conducted from March 2 to March 30, 2026. 17 experts were given the questionnaire, but only 16 completed the questionnaire, giving us a response rate of 94.1. And of the 24 statements evaluated, 21 or 87.5% reached consensus. So let's go to the first objective. For the definitions of intracranial atherosclerotic disease and intracranial atherosclerotic stenosis, this is the first recommendation. Intracranial atherosclerotic disease is defined as a progressive, pathological process characterized by atherosclerotic plaque formation affecting major intracranial arteries at any stage of the disease, encompassing both non-stenotic and stenotic lesions. There was 100% concurrence, thus a consensus. For statement number 2, intracranial atherosclerotic stenosis, or ICAS, is defined as more than or equal to 50% luminal narrowing of a major intracranial artery caused by an atherosclerotic lesion. 93.8% agreement, thus a consensus. Statement number 3, ICAS is considered symptomatic when an ischemic stroke or transient ischemic attack, TIA, within the vascular territory of the affected artery is attributable to the underlying atherosclerotic lesion. Again, 100% concurrence, thus a consensus. For statement number 4, attribution of an ischemic stroke or TIA to a specific intracranial atherosclerotic lesion requires the absence of a more likely alternative cause of the ischemic event. 75% agreement, the threshold is 80%, so there is no consensus for this statement. For the 5th statement, ICAS that does not meet the definition of symptomatic disease is considered asymptomatic. Again, 100% agreement, therefore a consensus. So let us go to the statement where consensus was not reached. The original statement reads, attribution of an ischemic stroke or TIA to a specific intracranial atherosclerotic lesion requires the absence of a more likely alternative cause of the ischemic event. So these were the feedback of the experts, and I quote, sometimes attribution may occur despite another etiology, such as atrial fibrillation. Another feedback, one or more etiologic factors may coexist and will need to be included. So the steering committee decided to remove this statement to avoid implying mutual exclusivity of stroke etiologies. The steering committee determined that the statement should be removed. A separate statement, which is included in statement number 3, sufficiently defines symptomatic ICAS without requiring additional clarification. Thank you.
Thank you, Doc Soc. So for our second speaker, she is a fellow of the Philippine Neurological Association and the diplomate of the American Board of Psychiatry and Neurology. She holds subspecialty certification in vascular neurology from the Philippine Neurological Association and neurosonology from the American Society of Neuroimaging. She also holds a master's degree in clinical epidemiology. She has served as the chair of the Vascular Neurology Subspecialty Board of the Philippine Neurological Association. So she will address the second objective of this consensus, which is the diagnostic modalities. So this segment will be delivered by Dr. Maria Teresa Cañete, Head of Preparatory Group 2.
Hello everyone, maayong hapon or maayong gabi. I've been awake since 3 a.m. and if I doze off, so sorry, I'm in stage 2 sleep. The objective number 2 is to provide tiered recommendations on the preferred diagnostic modalities for ICAS and their roles in screening, confirmatory evaluation, detailed characterization, and monitoring according to clinical indication. This consensus will set both minimum standards and ideal targets to account for the diversity of healthcare infrastructures across Asia. The research question 2.1. What are the different diagnostic modalities used for ICAS? 2.1a. Which diagnostic modalities have been used for the assessment of ICAS, as reported in current clinical practice guidelines, consensus statements, reviews, and primary studies which have described and evaluated such modalities? 2.1b. What are the reported diagnostic performances? That is, sensitivity, specificity, predictive values, accuracy of these modalities. So this is the PRISMA diagnostic flow for the questions 2.1a, 2.1b each, starting from about 1,686 articles and down to 137 that were reviewed for question 2.1a, while 2.1b started with 937 and ended with selected 27 studies. 17 were Asian and 10 were non-Asian. For research question 2.2, what are the respective roles of these modalities in screening, confirmatory evaluation, detailed characterization, monitoring according to clinical indication? 2.2a, which diagnostic modalities are acceptable, ideal, and not recommended for 1, screening or initial evaluation, 2, confirmatory diagnosis, 3, detailed characterization, and 4, monitoring of ICAS, as reported in current clinical practice guidelines, consensus statements, and reviews? What are the recommended clinical indications for each of the above purposes? 2.2b, what stepwise diagnostic sequences have been described or recommended? That is, which modality should be used first, which modality should be used next, if the first is unavailable or inconclusive, and which acceptable alternatives exist based on facility capability by current clinical practice guidelines, consensus statements, and reviews, if any. Again, these are the PRISMA flow diagrams starting from 1,686. We reviewed, selected 35, 13 from Asian and 22 from non-Asian, and 2.2b question again started with 1,686, and we ended with 4 articles selected. 1 is Asian and 3 non-Asian. The results of Delphi, round 1 for objective 2, statement 6. For the diagnostic evaluation of ICAS, a multimodal approach may be applied to ascertain the diagnosis and/or identify disease phenotypes that may influence clinical management, prognostication, or research eligibility. 100% agreement, thus consensus was made. Statement 7. Digital subtraction angiography remains the reference standard for the detection and quantification of intracranial arterial stenosis. This is a lower agreement of 81.3. However, since we set agreement of 80% to be consensus, so we still achieved a consensus outcome. Statement 8. For the initial evaluation of suspected ICAS, non-invasive vascular imaging using CTA, or computed tomography angiography, or MRA, magnetic resonance angiography, is recommended. Agreement 100%, and the outcome is consensus. In Statement 9, selection of non-invasive vascular imaging should be guided by patient-specific factors, vascular territory of interest, and local expertise and availability. Agreement 100% and consensus was achieved. Statement 10, transcranial Doppler ultrasound, that is transcranial Doppler, transcranial color-coded duplex ultrasonography, is reasonable for the screening of intracranial arterial stenosis. However, abnormal findings should be confirmed with non-invasive or invasive angiographic imaging if warranted. Agreement is only 93.8%, but this is also considered a consensus. Statement 11, the complementary use of non-invasive modalities may be considered to enhance diagnostic confidence and identify the need for invasive angiographic evaluation. Agreement is 93.8% and consensus was achieved. Statement 12, DSA is recommended when precise angiographic characterization of intracranial stenosis is required to guide clinical decision-making, endovascular intervention, post-intervention assessment, or clinical trial enrollment, or when non-invasive imaging findings are equivocal or discordant with the clinical presentation. Agreement is 87.5% and consensus was achieved. Statement 13, clinical or imaging features inconsistent with atherosclerotic disease should prompt targeted evaluation for alternative intracranial arteriopathies or competing stroke mechanisms. 100% agreement and therefore consensus was achieved. Statement 14, and I think this is very interesting, intracranial vessel wall MRI or vessel wall MRI may be considered as an adjunct to luminal angiography when etiological differentiation between atherosclerotic and non-atherosclerotic intracranial arteriopathies is necessary. Sorry. So agreement is 87.5% and consensus was achieved. So later we may ask, what kind of MRI is this? And we were speaking with Bonnie earlier that it doesn't have to be the high imaging. Sorry. May I have some water, please? So it must be late. So the vessel wall imaging that is being used is not the high-class MRI only, but even 1.5 Tesla can be used to look at the intracranial vessel. Agreement is 87.5% and consensus was achieved. And statement 15, intracranial vessel wall MRI may provide additional information regarding atherosclerotic plaque characteristics and plaque location relative to the perforator or branch artery ostia. Agreement is 93.8 and consensus was achieved. So before I forget, the workers of this question number 2, including Mel and Faith, really did most of the hard work, and research was fun because they enjoyed the process so much. So thank you in advance. Statement 16, collateral status assessment on angiographic imaging may aid, which is DSA, CTA, MRA, may aid in prognostication and hemodynamic evaluation in symptomatic ICAS. So prognostication, especially, for example, if we think that it is with ICAS that we have early neurological deterioration or even recurrence, early recurrence they say, or we don't have enough evidence yet, that it's the biggest risk factor for recurrent stroke. Agreement is 100% and the outcome is consensus. Statement 17, transcranial Doppler ultrasound may be considered for longitudinal monitoring of angiographically confirmed intracranial arterial stenosis. Agreement is 81.3% and consensus was achieved. So almost not agreement, mambaba yung consensus. But for us who do ultrasound, parang may love pa rin kami sa ultrasound. But this is not anymore maybe popular, no? But at least we know that it's useful for some things like longitudinal monitoring. Looking back at statement 7, the original statement is digital subtraction and geography remains the reference standard for the detection and quantification of intracranial arterial stenosis. An expert gave us a feedback, which the steering committee decided it was worth noting. Should we keep the term detection or replace with confirmation? And the steering committee's response is revise. Detection was replaced with confirmation to better reflect the role of DSA as a reference standard rather than as a screening modality. Tama naman. The revised statement now reads, DSA remains the reference standard for the confirmation and quantification of intracranial arterial stenosis. The steering committee determined that these revisions do not materially alter the intent or meaning of the statement. Consensus is therefore retained and the statement will not be carried forward to the next round. Again, a look at statement 12. The original statement reads, DSA is recommended when precise angiographic characterization of intracranial stenosis is required to guide clinical decision-making on the vascular intervention, post-intervention, assessment, or clinical trial enrollment, or when non-invasive imaging findings are equivocal or discordant. Excuse me. So an expert said, the feedback is that clinical trial details are required and may not be warranted for non-interventional trials. So DSA should not be needed for clinical trial enrollment. And so it is revised that clinical trial enrollment was removed, and again, this is not universally acceptable. So the DSA is recommended when precise, angiographic, etc. They took out clinical trial enrollment. Thank you.
Thank you, Dr. Nsai. So before we proceed with our last objective, we will be having a short break, a short 10-minute break. But just a reminder, all questions will be addressed during the open forum and panel discussion following the presentations. But if you think of questions right now, you can scan the QR code and register, and it will be addressed later in the open forum. So please be back on time so there will be no delay. Thank you. I'm sorry, Dr. Navarro decided that we will forego of the break and go ahead with the rest of the presentation. So our third speaker is a fellow of the Philippine Neurological Association and a certified specialist in vascular neurology. He currently serves as chair of the Department of Neurology at Baguio General and holds academic appointments as chair of the Department of Neurology at Baguio General at Pine City College's School of Medicine and professor of neurology at St. Louis University School of Medicine in Baguio City. So he will address the third objective of the consensus, measurement of stenosis and grading of severity. So this statement will be delivered by Dr. John Harold B. Hiyadan, Head of Preparatory Group 3.
Right, so on behalf of the third group, preparatory group, Dr. Escabillas is here, Dr. Cinco, Dr. Basalio, and Dr. Dan Wangco. And of course, Bonnie. Bonnie is a member as well as a leader of all the preparatory group. No? He's been coordinating everything. So the third objective of this ICAS consensus is to set uniform methods for quantifying stenosis, grading, severity across modalities, and to standardize the documentation of other diagnostic variables relevant to ICAS. So to answer that objective, the following research questions were formulated. How should the quantification of luminal stenosis in ICAS be performed? Which formulas, measurement criteria, or reference standards have been used for the quantification of luminal stenosis in ICAS as reported in current clinical practice guidelines, consensus statements, reviews, and primary clinical studies which have introduced, defined, or validated such stenosis quantification methods? And what is the inter and intra-observer reliability of this stenosis quantification method across the modalities? So, for the first question, sub-question, which formulas, measurement criteria, reference standards for quantification of luminal stenosis, we were able to search about 1,686 references from Scopus and PubMed, and about 28 citations from other sources. And with the removal of duplicates and with article abstract and title screening and full article eligibility screening, we were able to come up with about 31 articles for synthesis. So the 31 articles included Asian as well as non-Asian articles. Okay. So for the sub-question 3.2, which answers the question, what is the inter and intra-observer reliability of the quantification method? There were about 623 references from Scopus and PubMed with added 7 citations. And again, with the removal of duplicates and screening, there were about 14 articles included for data presentation and synthesis. So for the second research question, 3.2, how should ICAS severity be classified? What thresholds or grading criteria have been used to classify ICAS severity across modalities as reported in current clinical practice guidelines, consensus statements, reviews, and primary clinical studies which have introduced, defined, or validated such severity thresholds or grading criteria? How do these severity thresholds correlate with clinical relevant outcomes? So this is the Prisma flow, answering the question, what threshold or grading criteria for to classify ICAS across modalities? Again, we started with 1,686 databases plus about 24 citations. With duplicates removed and article screening, we were able to get about 55 articles for data synthesis, for data presentation and synthesis. For the second question, how do this severity threshold correlates with clinical relevant outcomes? We have a robust number of databases, 3,405 references from databases. And again, with screening, we were down to about 18. For research question 3.3, okay, which additional diagnostic variable should be standardized for documentation in ICAS assessment? Which vessel wall MRI-derived parameters, apart from luminal stenosis, have demonstrated clinically relevant diagnostics and or prognostic value in intracranial atherosclerosis? Which parameters derived from TCD, TCCD, or perfusion imaging have demonstrated clinically relevant diagnostics and or prognostic value in intracranial sclerosis? And which angiography-based parameters, apart from luminal stenosis measurement, have been associated with clinically important outcomes in ICAS? So again, showing you the Prisma flow diagram for the above research questions. We started with 863 references from Scopus and PubMed, and we were down to about 28 to be included for data analysis, data presentation, and synthesis. For the second question, about 190 databases, references, and we're down to about 32 articles. That is pertaining to TCCD and TCD, and as well as perfusion imaging. So for the third question, which angiography-based parameter, apart from the luminal stenosis, have been associated with clinical important outcomes in ICAS? Initially 340 articles were included, and again, with screening, removal of duplicates, we were down to about 24 articles. So after data synthesis, with data synthesis, recommendations now were formulated by the group pertaining to transcranial criteria for screening of intracranial stenosis, which is labeled as Statement 18 and 19. For Statement 18, for the detection of intracranial arterial stenosis using TCD, transcranial Doppler ultrasound, the use of standardized diagnostic criteria presented in Table 1 is recommended. However, no consensus was achieved because of less than 80% agreement. Take note, our criteria is for consensus would be an 80% agreement. It only reached about 62%. For the Statement 19, interpretation of transcranial Doppler ultrasound findings should account for systemic hemodynamic factors and proximal extracranial steno-occlusive lesions, which may substantially influence intracranial Doppler velocity measurements. This statement attained consensus with 93.8% agreement. So just to show you the table for the table of the TCD ultrasound criteria for detection of intracranial stenosis. Okay, so it focuses on the mean flow velocity, okay, as well as of the MCA, ACA, PCA, basilar artery, okay, and the rest. No, okay. It also includes like flow, velocity turbulence, high frequency turbulence, blunted waveforms, reduced pulsatility, dampened waveforms, and the like. So, pertaining to the quantification of intracranial artery stenosis, we have 3 recommendations labeled as Statement 20, 21, and 22. For the quantification of intracranial arterial stenosis, luminal diameter-based measurement aligned with the WASID method is recommended, with 93.8% agreement, hence the consensus. For Statement 21, when 3-dimensional angiographic reconstruction are used for intracranial stenosis quantification, luminal diameter measurement should be confirmed on source images. With this recommendation attained 87.5%, hence consensus. For Statement 22, for the classification of intracranial artery stenosis severity, WASID consistent percent stenosis category should be used. For moderate stenosis, 52 to 69% stenosis. Severe would pertain to 70 to 99% stenosis, and occlusion would be 100%. So, consensus was attained with this recommendation. So this is to show you the WASID way of computing the stenosis. Okay? So 1 minus D stenosis over normal times 100%, where D stenosis is the luminal diameter at the site of maximal stenosis, and the D normal, okay, is the luminal diameter at the reference and normal artery selected using the following criteria. And that should be in order, no? A, B, C to E, F. No? Okay? So, A, D normal is measured at the widest, non-tortuous, angiographically normal proximal segment of the same artery. If the proximal segment of the artery is deceased, D normal is measured at the widest, parallel, non-tortuous, angiographically normal distal segment of the artery. So, the priority is the proximal. Okay? Kung hindi tayo makakuha sa proximal, the distal to that stenosis. If the entire intracranial artery is deceased, D normal is measured at the most distal, okay, parallel, non-tortuous, angiographically normal segment of the feeding artery. So the more proximal artery. So if di tayo makakuha sa MCA, because fully stenosed yung stenosis natin, kukuha tayo sa most distal part of the ICA, right? So for pre-cavernous, cavernous, and post-cavernous internal carotid artery stenosis, D normal is measured at the widest, non-tortuous, angiographically normal portion of the petrous internal carotid artery with parallel margins. If the entire internal carotid artery is deceased, D normal is measured at the most distal, parallel, angiographically normal segment of the extracranial internal carotid artery. The contralateral circulation should not be used as the normal reference artery. When focal arterial segment demonstrates non-visualization of the residual lumen at the site of the maximal stenosis, such that D stenosis cannot be measured using calipers, percent stenosis should be classified as 99% luminal stenosis. So, pertaining to the advanced and investigational assessment of intracranial arteriosclerosis, we have 2 recommendations, Statement 23 and Statement 24. Hemodynamic assessment of intracranial atherosclerosis using computational fluid dynamics, quantitative MRA, and perfusion-based imaging modalities may improve risk stratification and treatment optimization. However, current evidence is insufficient to support widespread clinical interrogation. And that has a good agreement with 87.5%, hence consensus. For the last statement, which is statement 24, neurovascular optical coherence tomography, or your OCT, and intravascular ultrasound, IVUS, enable high resolution plaque and vessel wall characterization. However, their safety and clinical utility in intracranial atherosclerosis remain unclear. With 75% agreement, therefore, no consensus was attained with this recommendation. So let's focus a bit on the statement that did not reach consensus. So for the statement, detection of intracranial arterial stenosis using TCD, the use of standardized diagnostic criteria presented in Table 1, I'll present it later, is recommended. Okay, so for the expert panel feedback, not all criteria imply the same probability to diagnose ICAS, suggest the combination of circumscribed relevant velocity increase plus other. Our previous publication has shown that these TCD criteria have limited value for the diagnosis of ICAS. So the steering committee responded by modifying the statement to clarify that the criteria are intended for screening rather than definitive diagnosis. The proposal to require a combination of circumscribed velocity abnormality with additional features was not adopted, as this may increase specificity at the expense of sensitivity. There is a trade-off between specificity and sensitivity. A footnote was added to indicate that concordant findings increase diagnostic confidence. So the steering committee revised the statement. So the statement reads, for the screening of intracranial arterial stenosis using TCD, the use of criteria presented in Table 1 is recommended. So this is now, even the table was revised. Okay, so the title now is that transcranial Doppler ultrasound criteria for screening of intracranial atherosclerosis. Intracranial stenosis should be suspected when one or more of the following are present. We have the velocity parameters and other hemodynamic and waveform parameters. Okay. So for the other statement that did not reach consensus, which is statement 24, neurovascular optical coherence tomography and intravascular ultrasound enable high-resolution plaque and vessel wall characterization. However, their safety and clinical utility in intracranial atherosclerosis remain unclear. One expert panel feedback, unclear whether optical coherence tomography is practical for intracranial arterial imaging. So the steering committee responded by revising the statement, or the statement was modified to reflect the limited and evolving evidence on intracranial vascular imaging modalities. So they revised the statement, the safety, clinical utility, and practicality of neurovascular optical coherence tomography and intravascular ultrasound in intracranial atherosclerosis remain uncertain. I think that's my last slide, but before I end, I'd like to thank the steering committee for allowing us to be a part of this endeavor. Dr. Navarro, Dr. Pedregosa, Dr. Robert Gan, and of course, Dr. Alan Belen. And for Dr. Navarro, our mentor, okay, the mentor always leading the way. So that photograph was taken in Benguet. All right. Actually, inisahan ko si Doktor kasi pinapunta ko siya sa far area. Ako, nandun ako nagsusurvey sa poblasyon. Si Doktor pinapunta ko sa my bridge. Thank you very much.
So thank you to our speakers for their comprehensive and insightful presentation. So your contributions have provided important clarity and direction for the advancement of the Asian ICAS consensus. So we will now open the floor for discussion. Participants in the hall may submit questions via the QR code or proceed to the microphones for live questions. So our colleagues joining virtually may send their questions through the Zoom chat or indicate if they wish to speak. So we now proceed to the open forum and panel discussion. Are there any questions from the floor?
You know, it's not necessarily a question, just comment. Why don't you just give a comment for this project? Not unless you appreciate the project, you will have no comment. Or if you appreciate it really very much, you don't have to talk anymore. But let me ask this question to the group. Do you like this project? You think it's something fruitful for us to do? Well, those people answering is a part of the project. we want to know the, you know.
Dr. Ramani, Dr. Sharma would like to be acknowledged. Could you please bring up his on screen? Dr. Vijay Kumar Sharma from Singapore.
Hi, Joy.
Hi, Vijay.
Congratulations for carrying out this massive amount of work. It's definitely very important. I have been telling at every conference, this is our own disease and we have to work on it. And you have already moved forward with really very clinically relevant questions and answers. And once we complete this work, it will serve as probably a very important, milestone to be used all over Asia, and not only Asia, even other countries. We'll refine, diagnostic, the prognostic parameters, and everything related to the multimodal imaging of ICAS. Again, congratulations.
Well, thank you, Vijay. We're really looking forward for you to be here so that we'll be able to discuss it quite well. Well, anyway, thank you so much for your comment. And we're looking forward to us again, your help, if and when we need another project to be done. I think we might go on the second Delphi rounds, and because I think there's 3 statements that did not reach consensus. I think we really need to go over it. Okay, you agree with that?
Definitely, yes.
Okay, yeah, thank you, Vijay.
Dr. Ramani, would it be okay to hear from you as well?
Hello, thank you very much, and hello to everyone there in the Philippines. Sorry I could not come. Yes, congratulations Joey and the team for doing this very important project. I echo Professor Vijay's comment. There's an important disease that we have the best insight in Asia into this, and we should answer these important questions. So again, congratulations. We await the results of round 2 and any other rounds that are needed. So it's important that whatever we do translates to clinical practice, that what we recommend can be done in all settings, both in high resource as well as low resource settings. So we need to bear that in mind. Not everyone has TCD, not everybody has MRI of the vessel wall. So please bear that in mind as we go through the information and make applicable recommendations. But congratulations, I look forward to the next round. Thank you.
Oh, thank you very much. Thank you very much, Ram.
Are there any other questions, clarifications from the floor?
Nijaster is online.
Professor Suwanuela, the president, the current sitting president of the Asia Pacific Stroke Organization, is online. If it's okay, can we hear comments from Dr. Suwanuela?
Yeah, thank you very much. Sorry, I was just joining. But again, I think this is a very important topic, and I'm really looking forward to the next round of Delphi, and hopefully we can come up with a good recommendation. Thank you very much.
Thank you, Professor Suwanuela.
Thank you. For your information, Nijasri here from Thailand was one of those neurologists who did an early epidemiological study on ICAS in Asia, especially in their country, in Thailand. And if you're interested, it was published in Journal of Neuroepidemiology, and you can go and look at this paper. And that's probably one of those work that really inspired us to do our own data in the Philippines. Yeah, thank you very much, Nijasri.
Thank you.
Dr. Epi Collantes from the Philippines is also online. Dr. Epi, would it be okay if we hear from you as well?
Thank you for all the hard work, especially Dr. Navarro and Bonnie and the committee also. So this is a very important and crucial framework, also a consensus, no? Because it will guide us, especially as you said, this is our disease, and it will guide us not only in the management, but in detection, in the diagnosis, and the improvement of patient care. Congratulations.
Thank you very much, Epi.
Since we have a member of the PNA BOG here in the person of Dr. Joyce Tenorio, sorry. JJ was here earlier and Mark. In the spirit of collaboration, I would like to challenge PNA to also come up with support for this consensus and to endorse this consensus.
We have a question here. Who asked this question? I don't know. Probably Vijay. In Singapore, the utility of MRI vessel wall imaging was also just recent. Do we want to encourage our neurorad people here in the Philippines to use it?
This is a wonderful modality. Number one, you should have a 3 Tesla MRI. So 1.5 Tesla, probably the resolution is not good. Currently, we use the criteria for if it is an eccentric plaque, then this is atherosclerotic. If it's a concentric plaque or narrowing, then this is a other kind of vasculopathy. I strongly believe that this is a very artificial kind of classification because there are many atherosclerotic plaque which may look like having a concentric narrowing of the lumen. But definitely at present, if your aim is to differentiate between atherosclerotic, ICAD versus a non-atherosclerotic ICAD, we don't have any other modality other than this, which is reliable. We use it not like in every single patient, but in selected patients where there is a high index of suspicion of non-atherosclerotic vasculopathy. Then it definitely helps. But I'm not convinced with the criteria which are being used at present, a very crude way of classifying concentric versus eccentric. It needs to be refined. And definitely over time, as the resolution of MRI, the vessel wall imaging is being improved, it will definitely improve over time. Using contrast over it, it enhances your sensitivity. But sensitivity is enhanced only in the way of studying inflammation, which can be seen if you are doing the high resolution vessel wall imaging in the early stroke period. If you delay it, then that enhancement may not be visible. So it helps. Definitely it's a helpful tool, not in every single case. In selected cases, yes.
Yes, we agree with this, Dr. We agree with this, Professor Sharma. We actually, to also add to the question, that's why we are very intentional when we worded vessel wall MRI. So traditionally, this modality has been referred to as high-resolution MRI. But we understand that in a lot of settings in Asia, where we don't have 3 or higher Tesla, higher field MRIs available, that's why we use the word vessel wall to refer to the target of the imaging, which is the vessel wall, rather than the capacity of the MRI. You know? So we agree that vessel wall MRI is very, very useful in intracranial atherosclerosis. Number one, to differentiate atherosclerotic from non-atherosclerotic arteriopathies. Number two, to determine which is the culprit plaque in cases where there are multiple plaques within an artery. And of course, to determine the location of the plaque relative to the perforators or the branch artery ostia. But again, we concur with the opinion of Dr. Sharma that this is not indicated for everyone. No? So we have to be very selective because it is very expensive. And at the same time, this should not replace digital subtraction and geography are more digital subtraction and geography, even in the differentiation of atherosclerotic from non-atherosclerotic arteriopathies. Okay, so like for example, Moya-Moya disease still would require DSA.
I think we're still so very far from that, no? Because number one, there are only about 1 or 2 MRI with Tesla 3 in our country. Is there any institution with Tesla 3? Yeah, only St. Luke's. St. Luke's has a Tesla 3. Wala na, Tesla 3 lang. Okay. So I think at this point in time, we cannot use vessel imaging for routine use for patients with ICAS. And I think we really need long-term data. No? We need the long-term data regarding the ICAS using vessel wall imaging. It's not because we saw something wrong in the vessel, we would conclude right away that that is the area, that is the culprit artery that is causing the stroke. I think we really need a long-term data on that.
I'd like to add and ask Dr. Sharma for help. We are going to embark on a sort of national study using MRA to pick up intracranial stenosis from stroke patients. And I would like to know also if that classification of eccentric versus concentric, will that work, or will we be able to use it to differentiate ICAS from non-ICAS? So we'd like to know also your experience in Singapore. But we will be able to use the multiple MRIs we have in the country and maybe train the Philippine neuroradiologists to start using it.
So first question about the MRI is that most centers use time of flight MRA to diagnose ICAD. It overreads. That's the whole problem with the time of flight MRA. You will be diagnosing a lot of patients with stenosis, which is not existing there, especially those which are around 50% to 55 or 60% range. So that overreads. What Joy was telling just now, about the 3 Tesla. At NUH only, we have 6 scanners which are 3 Tesla, 3 MRI scanners in one hospital. And we do high resolution or vessel wall imaging with or without contrast, probably 2 or 3 in a month, not more than that, while we see more than 100 strokes per month. So 2 or 3 cases, only when the clinical question is, are we dealing with atherosclerotic versus non-atherosclerotic vasculopathy? With 1.5 Tesla, the problem is the resolution. The resolution does not permit you with certainty. But having said that, if you don't have any other modality, CT angiogram is a luminogram. It does not show the arterial wall. DSA, it is a luminogram. It does not show the arterial wall. If your question in mind, TCD is same. It shows you only the flow velocities, does not show arterial wall. So if anybody is studying atherosclerosis, then MRI is the only modality which is showing you the vessel wall. But 1.5 Tesla, I'm not convinced that you will be coming with reliable answers, because ultimately you will have to use some reference standard, and the reference is a different reference. If you do DSA as a reference, that is a luminogram, and you are comparing against a structural imaging. The comparison is valid to a certain extent, but not completely, reliable validation can be done. 1.5 Tesla, probably I will not be jumping on studying atherosclerosis with 1.5 Tesla, unless you have a 3 Tesla. For diagnosis of just a stenosis, we did one study with MRA compared to TCD. The agreement rate between the two is almost there, except what I told you, MRA will diagnose a little bit more than what TCD will diagnose. But still, it is within acceptable limits. If you are using MRA, time of flight, for diagnosing ICAD, then I will advise you to do at least 2 non-invasive imagings, not 1. You can combine MRI and TCD. You can combine MRI with CT angiogram, one of the two, but not structural imaging, definitely.
To address the concern of Dr. Sharma, actually we're very intentional with the wording of the recommendation, since we understand that the capabilities of different centers, different settings across Asia differ. So what we advocate for is a multimodal approach. No, and we didn't, even in recommending MRA, we didn't say the specific type of MRA, because there are so many: contrast enhanced, time of flight, zero time echo, etc. And even the post-processing technique, we didn't specify anymore, because we want to accommodate to the different settings in the region. And we made a separate statement to state that the choice of non-invasive angiographic imaging should depend on patient characteristics, the artery of interest, etc. And also, the center capability. And also, we understand that sometimes one non-invasive diagnostic modality is enough to ascertain the diagnosis. That's why we made a statement to state that combination of multiple non-invasive diagnostic modalities could be used to aid us in identifying which patients really need an invasive imaging like DSA.
Anything? Yeah, Joyce.
Good afternoon, everyone. On behalf of the PNA Board of Governors, I would just want to respond to the manifestation of Dr. Sarfati. And being a stroke neurologist as myself, I really appreciate, I am deeply honored to be part of this endeavor. And we will look into this, and we will be discussing regarding the endorsement, because I understand the WSO and the APSO have already endorsed this, and PAVIN have already endorsed this Asian ICAS consensus. Thank you.
So, no other questions or comments? All right, so I think before we end, I would like to thank all members of the expert panel and everyone who participated in this consensus conference for your important contribution. The results of Delphi Round 1 represents an important step towards achieving consensus. Equally important are the insights raised during this meeting, especially the one raised by BJ Sharma. And we are really going to look into that, discuss it, and be able to get the opinion of all the members of the project. This will be carefully reviewed and incorporated into the post-conference refinement statements, informing subsequent Delphi runs. So once we have established, modified, and did corrections on those statements that did not reach consensus, so we'll try to do it on the second round of the Delphi rounds. And with the aim of strengthening both the precision and applicability across diverse clinical settings. So we all know that what they're doing in other countries will not be, same as what we're doing here in our country. And we aim to finalize and publish this consensus, okay? And hopefully you will be anticipating the publication of this consensus, and you can use it in your practice, clinical practice. And we hope that within the year, before the end of 2026, we'll have the consensus published. Because I understand that there are already some journals anticipating for this consensus. As a matter of fact, there are some journals already written us to have this consensus be published in their journal. And in parallel, we will commence the second phase of this initiative, focus on establishing research standards and priorities. So again, once we have established all the important points that we have raised in our consensus, then I think we are ready for research now that we have the same standard definition and diagnostic test that we can use. And it's a high quality, comparable, globally relevant and equitable research in intracranial atherosclerosis disease. So with that, I would like to end. Okay, we have another question. Let me see. Do we have diagnostic or characteristic lesions thickness guidelines in differentiating atherosclerosis versus non-atherosclerosis stenosis?
Okay.
So we want to, okay.
So I think this question refers specifically to vessel wall MRI, if there are specific parameters which would help us differentiate. So actually, as part of the review, we looked at this. So there are several key parameters, may mga lumilitaw. Notably would be the enhancement, plaque enhancement, the pattern of enhancement, the remodeling, the pattern of remodeling, and also yung eccentricity, is it intrinsic, extrinsic, etc. However, the evidence is not enough for us to make clear recommendations on this. So regarding the differentiation between atherosclerotic and non-atherosclerotic arteriopathies, we recommend that the investigation should be targeted based on what you think the alternative etiology is. So by the inflammatory markers, if you're thinking of inflammatory vasculopathies, work up for infectious diseases if you're thinking of an infectious cause, etc.
Well, I think if we can collaborate, all of us can collaborate, give us the data of your patients with ICAS, whom we would be able to identify right away to be atherosclerotic, then we can easily remove the other causes of ICAS. It's not moya-moya, it's not dissecting, probably it's not infectious in nature. So once we have that data, we can analyze that and then write it up, and then once you have an ICAS, and then with following characteristic, you can immediately say that this ICAS is secondary to atherosclerosis. So we don't have to think of moya-moya, dissection, or other causes of ICAS. So I think that's a challenge that we want to put to ourselves. Let's get together, look at our data on ICAS, see amongst them our data whom we would be able to look and then diagnose to be atherosclerosis. Okay, I think that's an easy one, right? That's an easy work that we could do, and then be able to come up with a good result. Okay?
Okay, so if anyone wants to join us, we already actually have funding for this. We're doing a national registry for ICAS, radiomics and genomics with Dr. Insay and Dr. Navarro. So you could just approach us if you want your center to be part of it, because currently we're in the process of finalizing the centers to be included.
Yeah, it's open. Anybody who's interested, you can join the group. and be part of the group. And the project is open to anybody who are interested. Okay? Alright. Again, marami po salamat dun sa mga membro ng PAVIN and PNA and SSP who joined this project. Thank you very much.